We know kidney transplant is the golden treatment for kidney failure, but what we also know is that Black patients are less likely to be transplanted.
In a recent survey at Moorfields, we found that 86% of people said that sight was their most important sense.
The greatest opportunity to change someone's disease trajectory is early in the disease, and that in our current healthcare system sits within primary care.
Diabetic eye disease and kidney disease are leading causes of disabilities, particularly in marginalised Black communities. Great pleasure to chair this session on, I think we've sort of like colloquially coined it, saving kidneys and saving eyes. What we're going to be doing in this session is we're going to be looking at pathways to actually increase screening and engagement for Black populations with kidney disease and with diabetic, notably which is diabetic eye disease. So it gives me great pleasure to introduce the panelists for this session. So we'll start over here with the gorgeous Hellena. I'm missing her popping, but I think she's tried to match you like a sister, so that's absolutely fine. So she's but you can see who she is. And then we got Dr. Yannicka Singh sitting right next to her. He very kindly asked me to attend a diabetes conference in Hamburg, so I'm very grateful, Marim Babad. And then I've got my sister from another mother, Prof, Roxanne, who is a lead nurse research at Moorfields. So what are we going to be talking about in this session? Well, we're going to be talking about saving eyes and saving kidneys. They're both diabetes-related complications. Diabetic eye disease and kidney disease are leading causes of disabilities, particularly in marginalised Black communities. And our goal in this session is to try and see how we can address the barriers and explore pathways for equitable healthcare and improve screening and care engagement.
Good afternoon, everyone, and thank you for joining us for this session. My name is Hellena. I'm a clinical academic nurse in diabetes and chronic kidney disease. Today has been really, really great for me. It's just been a great experience, and I hope you all enjoyed your morning session, and we will make it entertaining in this session as well. Okay, so I'll start off by talking to you about the unique problem of diabetes and chronic kidney disease in the Black communities and what are the sort of challenges. And I will then highlight some of the current gaps in practice which are probably contributing to the inequities that we see. And I'll end by really calling for action for all of us what we could do to address these problems. So this is just really to highlight some of the data that we know about Black population in relation to diabetes and chronic kidney disease, as well as I think this is to be true for cardiovascular complications as well. So there's disproportionate disease burden when it comes to diabetes and kidney disease in the Black communities. And often what happens is patients from a Black background tend to present with an advanced kidney disease when they come to our clinics. And that's because they've missed on checks and care that they should be getting. And there's a number of reasons for that. What we also know from a dialysis data is Black patients tend to end up on dialysis 3 to 5 more times than the white counterparts. And they tend to present at a younger age compared to a white population. We know kidney transplant is the golden treatment for kidney failure, but what we also know is that Black patients are less likely to be transplanted, and they tend to wait on average 2.6 years longer than a white counterpart. So these are all really stark data and something that we all need to be reflecting about and thinking about how we should address that. So in terms of the other key challenges is the clinical gaps that we have. So the image that you see in here is the diabetes model of care in England, which has a 4-tier system, which I won't go into because many of you in the room will know that. So people with advanced kidney disease at CKD stages 4 and 5 are expected to receive their kidney care in secondary care provision. What we found in our work in North Central London, so looking after patients of with diabetes and kidney disease. So we are looking at a number of 291 patients with the condition. When we audited where they actually received a diabetes care, only 6.5% of patients receive ongoing diabetes management. So the remaining 93.5% of patients actually are not receiving the specialist care that they require. So they're really clearly demonstrating the policy implementation gap. In terms of renal services, we all know that a large proportion of renal services actually are managed by primary care colleagues. About 78% of the management of CKD lies in primary care. And there's a variation in terms of the delivery of support that they get from a nephrology service. So in one side of London, you may have a brilliant nephrology input for the GP services, and the other side of London, that doesn't exist. And when we talk about nephrology services, really what we're talking about, to be under a consultant nephrologist, your EGFR has to be under 30. You lost about 70% of your kidney function. I'm not sure that's ideal, and I'm not sure that would meet the needs of people. It's too far gone. I think we would need to try and prevent these diseases. So what we have on the screen is disparities in terms of coding, and this is a data from Lambus Net database, which this is a work led by Professor Nitish, a colleague of mine in North Central London, looking at coding and disparities. And what they found, so they had something like 286,000 patients in the baseline population. Of those, something like 99,500 had CKD. Of those patients, only 45% of them were actually coded. And when they then looked at actually who's coded, who's not coded, if you are a Black patient or from African background or Caribbean background, you're less likely to be coded. And this is true for younger patients and South Asian heritage patients. What this tells us is we know if people are not coded, they're not necessarily going to get the surveillance that they need and the care and the management and input that they so desperately need to actually prevent poor outcome. So it's really an exciting time in diabetes kidney disease. We've got a lot of options in terms of therapies, but how are we doing when we look at ethnic minority populations? So I'm going to share this data with you, which just been published in the last week also. And this is a US-based data. I think that it will be very true if we look at data from the UK. So what we're looking at here is this is over 1 million patients with diabetes and cardio-renal conditions. So that would be your cardiac conditions or chronic kidney disease and type 2 diabetes. So if you are a Black patient, you are somewhere in the region of 24 to 30% less likely to be prescribed SGLT2. And similarly, in terms of GLP-1, you are less likely, about 30 to 33% less likely to be prescribed GLP-1. Now, we know that these medications modify disease progression and improve outcome. So if we're not intervening in a high-risk population to provide this care, we're going to end up with poor outcomes. So I'm going to end with call to action for all of us in the room. So the policymakers in the room, can we please examine the care models that we have and think about addressing inequities and improving outcome? For all of us, the clinicians in the room, what I'll say is let's get the basics right, from diagnosis to coding to prescribing. For people who are living with diabetes or chronic kidney disease, let's change the narrative and let's make sure that we receive our health checks and let's control of our conditions. Thank you for listening to me.
Hi, thank you for having me. So my name's Roxanne and I'll be doing the eye presentation in front of a consultant. Well, let's see how we go. So we have some topics to be covered. So what is diabetic eye disease, the impact on our patients' lives, the prevalence within the UK Black population, looking at the engagement of our Black population, but also focusing on a Black population, what are the common barriers to eye care that we found. So a quick overview, and I think we should know this for a diabetes conference. We have lots of people in the world with diabetes, and the numbers are, thank you, numbers are increasing year on year, and we know that 90% of our patients with type 2 have type 2 diabetes, and there's going to be an 11% increase by 2020 from 537 million to about 643 million. We also know that the complications of diabetes, as presented by my two colleagues previously, account for about 10% of our NHS inpatient budget. And that's not talking about our outpatient budget, where these individuals are seen. But we also know that people with long-standing diabetes, some may have eye disease and then some may not have eye disease, but let's get into it. So how important is your sight? Quick question. In a recent survey at Moorfields, we found that 86% of people said that sight was their most important sense. This data was also replicated in 2016 by our colleagues in America, asking individuals just randomly, which of the following ailments would you prefer not to have? So between blindness, cancer, HIV/AIDS, or Alzheimer's. As you can see in blue, most patients chose not to have blindness because they fear the loss of their independence. And I think that's replicated in this audience. So what is diabetic eye disease? We term it as a chronic progressive sight-threatening disease of the retinal microvasculature, similar to kidney disease, and is associated with prolonged high blood sugar and hypertension. But unfortunately, it's the leading cause of treatable blindness in the working age group in the UK, but across the world is the leading cause of blindness, period. The RNIB, so the Royal National Institute of the Blind, showed in 2021 that 97,000 people in the UK currently suffer with sight loss due to diabetic eye disease. Now, how does that impact on us as professionals, but also on our patients? There are huge socioeconomic impacts. We're talking about reduced quality of life. Not if you can't see sometimes and you don't have the socioeconomic provisions, you're not able to go out, you're not able to hold down a job. It affects your general health, your mental health. Also psychological distress. Those of us who do lots of diabetes research, our patients always talk about the distress that it causes them and the anxiety and then depression. We also know about the social and emotional strain these individuals tend to suffer from, loss of independence, especially as you get older. Some individuals, as they progress along the diabetes journey, so we spoke about dialysis before, their mobility may be decreased if they've got peripheral neuropathy, and that tends to impact on their social activities. And just skipping through to the end, just recently we've got some paper and some research looking at sleep quality based on the eyes. Diabetic retinopathy leads to poor sleep quality because it affects your circadian rhythms. So what's the prevalence of this condition? So looking at my grid, I've got 100 people represented here on this grid, totally in blue. We know that 30% of our population currently are between the ages of 0 to 19, and 70% of our population are over the age of 20. So in terms of diabetes, we know that 10% of people over age 20 have diabetes. We also know that 1/3 of people with diabetes, that's the orange, have diabetic eye disease or retinopathy. And then we know that 10% of the people with diabetes have sight-threatening disease and need treatment. I call her Miss Evie. Miss Evie spoke about this earlier on, that the only data that we actually have for ethnicity in terms of diabetic eye disease is in 2012. And we did this paper with my supervisor, Ms. Silva Prasad, in 2012. And look at the numbers outlined in red. So for this paper, we showed that the prevalence of any diabetic eye disease was 37.4% in white Europeans and was 52.4% in Afro-Caribbeans. South Asians were also 42.3%, so obviously higher than the baseline population. Looking at sight-threatening disease, we showed that in Afro-Caribbeans it was always also more prevalent. It was 11.5% versus just 5.5% in the local white population. This paper I'm showing is just from 2023, looking at North London diabetic eye disease screening service. And they've shown in this paper that their patients of Black origin or Black ethnicity were 2 times more likely to develop sight-threatening disease than the local white population. So how many years between is that? 12, 15 years? And the data still hasn't changed. Let's look at engagement in screening in Black UK populations. So quite interestingly, this paper showed that 16% of their population was Black and 36% was South Asian. However, they reported in their outcomes that there are some ethnic differences to the uptake of diabetic eye screening. However, the problem is among our Asian patients, not really our black patients, because our black patients attended around the same rates as our white patients. So if that's the case, why is it that there are worse treatment outcomes in the black population? Where is the racism, or where is the gap in services? Is it at the GP level, so they're not being referred in? Or is it in the secondary care level after they developed eye disease, if we're saying that screening is working? Just saying. So we did this study. I got funded by the NIHR to do this study called Prioritise, looking at improving the rate of non-attendance in people over the age of 30. And this is the data I found speaking to lots of people, and also to my colleague here on the screen, on the stage, Hellena. So I asked individuals across Southeast London and across the country, actually, why don't you attend your diabetic eye screening? I specifically spoke to patients who don't attend. So some of the bubbles, no one told me. One very interesting patient said, they gave me the information, but I can't read. So what am I supposed to do with it? Another patient said, I've got 28 days annual leave, 25 are used for other diabetes appointment. I want to have a holiday. I could not go to my screening appointment. Another one said, I attended with my grandson because a letter came in the post, but I don't understand what it's for. So therefore, when she got her letter for the outcome in terms of controlling her diabetes and her metabolic factors, she hadn't got a clue what to do, but she was told to attend, so she did. And that's the numbers that we are seeing in that previous paper. They were told to attend, so they did, but who was helping with their diabetes management thereafter? Just saying. Our healthcare professionals. One thing that really struck me was my first chat with a GP and a practice nurse, and I'm not down on anybody because I know these individuals are overworked and underpaid. But they both said to me, there are 8 things that we have to check for diabetes, but eyes is number 10. She literally said, on the system, the diabetic eye data is stored in the eye section, not the diabetes section. She only has 10 minutes for an appointment, so therefore she'll have to log off the diabetes section, log into the eye section to determine whether the results were there, whether they actually attended screening, and then log back into the diabetes section. And then consequently, she's like, well, I don't actually understand what the eye data means, so therefore I rather avoid discussing it because I can't explain it. Sorry? This data was done this year, and it was on an EMIS system. Yeah. It's actually done in July this year. So I'd like to see your system. And then another person said, because the eye came off the quality outcomes framework, because we used to get paid for checking that, it's not my role to check. So therefore, they need to go to screening on their own. It's not my business. So what have we done to promote that? So my group and I do lots of outreach sessions promoting eye health and research in underserved communities. We got our permissions to show these images. This is a black majority church, and on the other hand, it's a Gurdwara. And we just take lots of leaflets out with our nurses, do basic eye screening, talk to the children, take out games, talk about different eye care, initiatives, talk about the importance of attending screening, importance of going to your opticians. Just briefly, before I finish, Ms. Evie, we've got individuals in the community, when you ask them, how do you wash your eyes in the morning? And they say they use soap and water on their open eyeballs because we've told them to wash their eyes. We have other individuals who say to us that they use a drop of lemon juice, a drop of honey, and a drop of onion juice in their eyes every day to help melt cataract. And this isn't just a tribal or a cultural thing. I've actually seen an individual present me with a book with a barcode that this is printed in, and that they are actually using this as a Bible to looking after their eyes. So the need for eye education out there is real. Simple table with the most common eye diseases, a game, you engage them, and you can change our individuals' lives. Thank you very much.
So thank you so much, Roxanne. So we're going to open up the panel discussion on this particular section. And yes, can we give the mic over to this lady at the back there, behind you? Thank you.
Hi, I'm Tolu from, I'm one of the consultants in Mid Yorkshire. Thanks to all the panel for a fantastic talk. I think the problem with black populations, or the problem we have in this country, is that the time of screening. So when you get to the age of 40, that's when you get sent this letter from your GP saying, oh, it's time for your midlife MOT. That's what I call it, the midlife MOT. But we know that black populations are 3 to 4 times likely to get diabetes, and also get diabetes probably a decade earlier. So should there be a national drive to, I think you mentioned it at the end of your talk, that perhaps we should tailor the screening to certain populations? So for instance, rather than having the midlife MOT at 40, perhaps we should do it at 30. Because by the time these patients come to your clinics, or our clinics, they already have established complications, and it's too late. You're just playing catch up. So if there's a drive to try and actively screen these populations early, then it means that we can then prevent any complications, and then also save the NHS money. But I think there seems to be a lot of talk about treating people, etc. But I think there needs to be a lot of work from the grassroots level to help with the screening, the push for screening a lot earlier.
So I agree. It's got to be personalized. So the idea that every person comes every 6 months to a diabetes clinic or a kidney clinic is a historical thing where people just book follow-ups. Our approach has to be stratified and prioritized to those at highest modifiable risk, right? And we waste a lot of NHS time and resource seeing the same people in the same clinic for very modest gains at the expense of high-risk people who never get into those clinics. So I agree, the whole concept should be screening early. If you have any risk factor and if you're in a high-risk group, your screening should start earlier, but your monitoring should be more as well, because your rate of progression will be faster. Does that make sense? So that's the concept, I believe, for kidneys and eyes and many other complications. But in terms of diabetes, these can be prevented and modified early. That's the advantage of doing that, compared to some other screening tools we have, which have limited long-term benefits.
Okay, thank you.
Hello. What about genetic testing? So, I mean, Africa is a huge continent. An African person from the west coast of Africa has got a very different risk of kidney disease if they have the APOL genes.
Wondering whether we should
That is most of the African diaspora, right? Is West African. So what about actually doing genetic testing? I mean, this is becoming, people can spit in the tube at, on holiday, which I did in 2019, and I found out all kinds of terrible things about what's going to happen to me later. But these genetic tests are actually now really accessible, and so we should be using them, I think, especially in these really high-risk populations, if you've got somebody who's got a family history of kidney disease, it shouldn't just be that you actually are, that you're black, right? The genetic side of it is so huge when it comes to chronic kidney disease.
So, yes, I think we should take a step back, however. I'm a slightly simpler person. If we can measure the urine albumin-creatinine ratio and the serum creatinine in everyone with hypertension and obesity and type 2 diabetes, we only do it 50% of the time, that'll be a start. And then we add in the genetics of APOL. But what I guess my point is that I don't want to say, let's just spend millions on genetic testing, because who goes for genetic testing?
Exactly.
Who is the people motivated? It's self-referral often, at least in our catchment area. I think if we encourage primary care to screen early for eye screening, kidney health early, doing the simple tests, and then keep the genetic tests, I appreciate it, for those at the next level. But APOL, of course it's important, but I guess I'm talking about diabetes specifically here, and not FSGS and other conditions where there may be a greater predisposition.
So I don't know whether anybody knows, when we're looking at genomic data, what proportion of genomic data that is out there for analysis, what proportion is from white populations, and what proportion is from what I would call the global majority that is non-white? Does anybody know what it is?
30% non-white.
No.
Not even that much.
Lower.
5%.
Lower. 4%. So 96% of genomic data is from white populations, and 4% is from the global majority. And it's ironic, really, because the global majority represents 80% of the population. So therefore, what Yannicka said is actually really pertinent. Does anybody have another question?
And sorry, Ms. Evie, I can trump that data. So the UK Biobank did an analysis last year, and 92% of the studies that actually, analyze the data anonymously only request white data.
Yeah. Well, like your SGLT2 inhibitors, there are no black people in those studies, so how do we know that they're going to actually save kidneys?
Yeah, but it's better than doing nothing, right? So I guess that's my point. Yeah.
And then moving forward with your data on genetic testing, great initiative. However, the mistrust is real in the community and data sharing. So we'd like to get there, but we have some work to do on the ground first, I think.
I agree, yeah. So I think...
I was just going to make one point to the point that Tolu made. I raised that question with Claire Hambling today, and the response was people that are 40 don't come for their checks. So we have to use the resource at that stage. But it was the same question I asked her when we've got the data that suggests that those from South Asian and Black heritage groups are at more risk, so we should be starting their screening, like Yannicka said, in their 30s.
Yeah, and most people who come for screening, for this healthy screening, are people in their 70s and 80s in prosperous parts of the UK. I'm just sorry. So the question is, why are you wasting the resource on people who are relatively well, who want to be confirmed as being well, if you like, when we should be utilizing the resource more strategically, rather than just saying everyone over 40 or under 40 doesn't turn up? That's just not right. It's just not useful use of the resource, in my simple opinion.
So I think we had a question here at the front. Oh, okay.
Thank you. I just wanted to highlight, you mentioned earlier, the gentleman in the middle, in terms of CKD and how many you see of people that have deteriorated so low before they get to you. I don't know what your opinion is about the NICE guidelines and the pathway that we currently have, in that is a fit for purpose, actually. It's what we've got and it's what we refer to. And I guess to a certain extent, these guidelines are put in place with the hope that people that are using it will use their intelligence rightly so, in the right place at the right time, to refer faster where they recognize the potential gain in doing so earlier. But there is a lot of therapeutic inertia within communities, within primary care, for a plethora of reasons, because it depends on where you're working from. If your focus is your QOF, your focus is on your funding that is going to keep your private practice going, then your priorities are misplaced anyway. So there's so many challenges from so many sectors that are not focusing on patient care. It's a very well-used words, but often enough, I just think people's priorities are misplaced, and therefore they will go for wherever they will get the most money. So forget the potential advancements and potential gain in sending people to secondary care earlier, especially Black population. If they're not engaging, nobody's going to be going after them. So therefore, how do we ensure that mindset in the first place? There are a few, I don't want to paint everybody with the same brush, and there are a few outstanding clinicians out there, but the reality is they're human, and therefore, for that reason, their priorities are already, impacted for that basic reason. I also wanted to highlight about screening. So, this talk is about eyes and kidneys, but of course with diabetes, there's so many other parts of the body that's affected. So therefore, when we're thinking about engagement, we need to do everything in one place. Yeah. So a system that covers every single thing. Unless that is in place, people are not going to be taking so many days to come in for different appointments to achieve the same little results.
Yeah, so there's quite a few comments. I think guidelines are written on the basis of resource, and we would all want to see people earlier in secondary care, but as you correctly said, the greatest opportunity to change someone's disease trajectory is early in the disease, and that in our current healthcare system sits within primary care. And I think the way I would envisage it being better is where Secondary care works closer with community primary care. I do one clinic a week in South London, in near Oval, in a poor part of Lambeth, which is a kidney clinic, but that's not enough. You know, Lambeth has 600,000 people, right? So we need more awareness and working in primary care to support primary care. I agree that people get referred too late. That's probably never going to change well past my retirement, but it's about getting the early care in primary care, giving confidence, but also raising awareness and education. For a busy primary care healthcare professional, diabetes is one of 50 other problems. There are social care problems, there are mental health problems, there are lots of other conditions. So it's our responsibility as physicians and specialists to engage with primary care and keep reminding them and working with them.
So I want Hellena to talk a little bit on the possibility of combined clinics for kidneys and for eyes with some of the work that you're doing.
Thanks, Evelyn. I think that's a great question. I guess what I was trying to demonstrate on my presentation is actually the policy gaps that we have, both in terms of diabetes as well as renal disease. So I guess the basic of it goes back to, if we think about every contact matters, then we should really be thinking about the system generally, not isolate the eyes and the kidneys. So I run a clinic in Moorfields on a Monday afternoon, and often, you know, the amount of people that come to my clinic who've never had their kidney screened, and that is a great opportunity to be able to intervene, because if we don't do anything, I'm going to see them in dialysis in the next few years. Everyone is overworked. The system isn't helping, at least our IT systems aren't integrated for us to know whether people have had the checks or when they will be having the checks. We're not good at communicating with each other. We often use the same drug to treat renal, cardiovascular disease, and, you know, to some degree, diabetes now, right? So we need to really break that silo of speciality working and think about the person and use and upskill ourselves to really help and make a difference. There will always be a challenge of convincing policymakers, because they have to make difficult decisions. But I guess, you know, we need to work in partnership with organizations who understand the patients and the population better. And Diabetes Africa and Bernadette have work. It really shows us as an example that we can make a difference. I guess that's what I will end on.
Thank you so much, Hellena. So I think that you were at the front, you're very patiently waiting to ask your question.
Thank you. My question is, are there any particular barriers that make Black patients less likely to be prescribed SGLT2 inhibitors? And also, I know there's some trepidation amongst GPs amongst prescribing these drugs. Do you see a way forward in how to overcome this and progress with prescribing more SGLT2 inhibitors?
Do you want to talk?
So I think there's a lot of miscommunication out there. So we first need to accept that clinical trials that are done predominantly by pharmaceutical companies predominantly recruit Caucasian white people, right? So the representation in clinical trials which get the license for therapies is modest in certain countries. Japan being an exception, where Japan only licenses drugs if there is a Japanese population study, right? So with that proviso, the question is, are we going to wait 20 years to studies that may never happen, or do we use and extrapolate the evidence from disease? Or do we do nothing? So I think my personal humble opinion is not just SGLT2s, it's the blood pressure control, it's the ACE inhibitor, it's the statin, it's looking at everything, get those optimized, and in the majority of people, I would offer an SGLT2 inhibitor, and it's about education and awareness. And one would hope eventually we will have data, but it's better than not doing anything when we have evidence that these drugs stop dialysis, stop heart failure, and stop cardiovascular death.
There's a question to be had there about research being equitable and how to hold the drug companies to account when they're doing their enrollment and having these sort of culturally responsible people who are doing the recruitment. Have we got another question?
Yeah.
Where's, oh, sorry.
Thank you. So Oge, GP in London. I was really interested in that chart with the progression, which is marked. Was it annually, the checks from 68 EGFR all the way down?
It's kind of some 2 years, some, but it's fast.
Yes, it was fast. My challenge is wanting to refer early. So if I was to refer someone with a CKD of 68, even if their ACR was a bit up to my local kidney clinic, they'll be like, monitor. They wouldn't necessarily accept that referral. There's a lot of like manage yourself in primary care, barriers to referring in because the system wants to keep care closer to home, but it's not resourcing that at the moment. So definitely and then the recall, people are busy. Like you said, I think these were done when someone would be admitted or there's a crisis rather than coming for the opportunistic check because people are busy. People are working shifts all around the clock. So in terms of how to highlight, like which groups do we risk stratify to try to get in at 6 months or 3 months instead of annually? Or if they don't come in annually, what other techniques would you suggest? And how do we emphasize the secondary care to look at this referral rather than say, no, it's not serious enough yet, It's almost like they want it to get to the 30, then they're accepting it. That's been my experience.
I can't help with the second one. It depends on your local hospital. But for prioritization, if you're young with diabetes, especially type 2, if you're hypertensive, and look at the previous kidney function results. Because if you look at the past, you will predict the future generally. So if someone is dropping from 90 to 70 to 60 over the last 5 years, that's telling you a lot. Is there something you can modify with their blood pressure, the salt intake, optimize their RAS inhibition, get them on the drugs that are appropriate? And generally, we are in secondary care, it's 15 mils per minute or 25% annual drop in EGFR, but that's quite advanced, isn't it? So I guess to me, it's those younger people with type 2 diabetes, especially Black people, South Asian. I have a large Hispanic population in South London, people who are from Colombia, Latin America, who have very similar rapid progression. People from North Africa, people from Thailand and Vietnam also have this similar rapid progression. So think about the ethnicity, think about the age of their onset of disease, look at the previous results, and also think about things like hypertension and obesity, which drives kidney disease progression, who need more frequent monitoring.
Thank you. We've got a question here. Thank you.
Can you hear me?
Yes, we can.
Hi, I'm Gemma. I'm a PhD candidate from the University of Oxford, but my work looks at the implementation of foot screening in people with diabetes in South Africa. Roxanne, I really enjoyed the quotes that you put up from both patients and healthcare providers. And I did a big chunk of qualitative work earlier this year from both patients and healthcare providers. And I have very similar sort of shared insights on why people's feet are not being assessed. One kind of additional thing that I shared with Evelyn downstairs in the stigma session was how people with diabetes are actually quite shameful or feel shame and have a lot of stigma around showing their feet. And that's kind of one of the barriers that my work is looking at. But another barrier is who is doing and conducting the screening. And I think in the literature, there's something to be said about synergistic interventions with eyes and feet and kind of foot screening going on in the period between pupil dilation and I think retinal photography. But both optometry and podiatry is very limited in many settings around the world, but particularly in Africa. So my question to you is, what are your thoughts on who is conducting the retinopathy screening? And maybe beyond that, what do you think the role of AI and technologies in this screening is going to play in the coming years, and potentially in contexts where there's sort of limited access to healthcare?
Okay, so is this a high resource or low resource setting? I think the answer will depend.
Can you give both?
So in a high resource setting like the UK, we've got the services in place and we've got resources in place to be able to do, as we do, separate screenings, but as we would like to do in the future, combined or one-stop shop screening, because we have a specialist to be able to do that. In a low-income setting, the lowest common denominator is usually the ophthalmic clinical officer, or it's usually the ophthalmic nurse. And these people are can be enabled to do all of those screenings when they go to the health setting. So I just finished a course for the London School of Hygiene and Tropical Medicine, and it just opened my eyes as to, the lack of access to care these individuals have. But if you can just train one person in a community, you can change that entire community's lives. So I think it really depends on the resources that you have. And what's the second question?
The use of AI.
Yeah, all for it. However, I also work at Moorfields one of my teams is an AI team, and we've got millions of images, and we can predict things like Parkinson's symptoms 7 years before the onset of the condition. Our biggest problem is data sharing. Patients are not giving permission to be able to share their data. And quick story, I remember doing my PhD back in 2012, and this African Caribbean lady, I went to ask her for a blood sample to check, different factors and stuff, and how does diabetes affect the brain, and can you link the eyes to the brain? And she literally threw her slipper at me because she said her blood sample was going to be available to the Metropolitan Police, who will then be able to trace her grandson who was involved in nefarious activities. And I thought, okay, that's 2012. And just yesterday, I heard that exact same excuse being used again for not participating in a study and not doing data sharing. So yes, AI is great, but then it will only be available in the populations that submit the data. We know, just data was from last year, we know that every day there's 117,000 gigs of white data and only 5,000 gigs of black data available. So who or what data are we training the AI on, first off? And then secondly, how do we get the populations to trust the use of this data before we can push it through?
So I am so sorry to inform you that this session has come to an end. And what I just wanted to say, I think it would be really good in an ideal world if we had a one-stop shop where you could have eye screening is from the age of 12 in the UK anyway. You have your eye screen, your kidney tests, your feet checked, everything in a one-stop shop that ideally took 20 minutes, that we had equitable artificial intelligence methods or whatever to be able to do this. But thank you so much for your engagement.